Hi, guys, it's Dr. Sadaf, and I would love for you to like and share this podcast and make sure you leave me a review. I'd love those 5 stars. So please, when you send me a review, please make sure to put the 5 stars in and to share the episode with somebody that you know that could really use it. And I would absolutely appreciate it. Also, if you're looking to schedule an appointment with me, make sure you go to my email and put your name on the email list. You will be the first to know when I open up my office in spring of 2024. It's drsadaf.com. And last but definitely not the least, September 16th to the 23rd, 2024, I will be hosting a retreat with Dr. Basma Faris in Morocco. You will be getting yoga and coaching, and we'll be doing excursions and cooking and spa and hammam and all of that great stuff along with meditation. So make sure you don't miss out. Spots are limited. So go to the link in my bio in both Instagram and TikTok to make sure you register. Enjoy the show. I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf Lodhi, and this episode is everything you need to know about urogynecology, what it is, and how it can help you in your intimacy if you're having any issues. But before I get into it, I want to make a few things very clear. I am not giving any type of medical advice. So if you're having any issues with intimacy or, let's say, prolapse or anything like that, definitely go and be evaluated and speak with your healthcare provider. And I'm definitely not giving any type of religious advice. So if you have any questions about your religion, make sure you go see your friendly neighborhood religious leader. This is a Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So here on with me today is a special guest from Allentown, Pennsylvania, and I'm going to let Dr. Noor introduce herself.
Yes. Well, thank you so much, Dr. Sadaf, for giving me this opportunity. I'm very excited. As a fellow Muslim woman, I think what you do is very exciting, and I'm really excited to be a part of this. So for your audience, my name is Dr. Nabila Noor. I'm a board-certified and fellowship-trained urogynecologist. So urogynecology, as you mentioned, is a relatively new field, which is why I feel that a lot of the times, both patients and even healthcare providers, and sometimes even physicians, may not be very familiar with it. We actually became a separate board certification only as of 2013. So you can imagine, compared to some of the other subspecialties of obstetrics and gynecology, we are very, very new. So as a urogynecologist, we go through specialized training after going through residency. So my background is also in obstetrics and gynecology, like you, Dr. Sadaf. So after completing my residency, I went through 3 years of additional training to do urogynecology. So essentially now, as a urogynecologist, I see patients with various different pelvic floor disorders, which could include issues such as urinary leakage, bowel leakage, pelvic organ prolapse. I do a fair amount of reconstructive work for patients who may have had trauma related to childbirth, urogenital fistulas, things like recurrent urinary tract infections, bladder pain, pelvic pain, pain with intercourse. So there's a whole gamut of conditions, some very surgical, some non-surgical, which keeps it very exciting.
Okay, great. Well, thank you so much. That's fantastic. And I know that there are definitely a lot of people that suffer
No
from
worries.
issues such as prolapse and, perhaps some fistulas or something. Just for those people that may not know, fistulas are basically connections that can happen sometimes. They can happen between the vagina and the bladder. It can happen between a connection between the vagina and the rectum. And sometimes that can happen if, say, for example, you had a tear and it didn't heal properly after childbirth. And so there can be a connection that forms. So your gynecologist deal with that. So do you do a lot of fistulas in your office? Do you see a lot of them?
I mean, thankfully, fistulas are not very common, which means, especially as a generalist, or our generalists are doing a really good job with repair. And as you mentioned, fistulas are false connections. So childbirth related trauma is definitely one of the factors that where we see it, especially the rectovaginal fistula, right? So these are women who maybe had a bad tear, so a third-degree laceration or a fourth-degree laceration, or maybe required forceps for their delivery, or they had an episiotomy where your doctor had to make a cut just to allow the baby's body to be delivered. And like you mentioned, if not done right, or maybe it was done right at the time of the repair, but maybe the wound broke down, maybe they had a vaginal infection or whatever it may be. If that wound doesn't heal, you can have that false connection forming, whether it's between the vagina and the rectum, or the bladder and the vagina. Now, that's known as what we called it could be a vesicovaginal fistula where the connection is between the bladder and the vagina. A lot of the times we do see it, especially for women who may have had some sort of iatrogenic trauma during surgery, such as hysterectomy, or maybe there was an injury that wasn't identified, and over time there was a false tract that was formed. So to answer your question, we don't see it as commonly, but when it happens, it can be really debilitating for the patients and can really affect their quality of life.
Yeah, absolutely. I mean, I know that I've seen reports on women in other countries that have to travel several miles that may not be able to get to an OBGYN, and then that head gets stuck, the fetus, if they're in labor, that head can get stuck in the pelvis and cause those connections to happen because they've been in labor for so many days without being able to deliver that fetus. And so that can definitely cause some crush injuries and cause some problems there.
Absolutely. Yes.
So specifically when it comes to intimacy and how you help your patients with that, talk to me a little bit about that.
Yeah, so the reason I even wanted to do this is because you don't necessarily think about like pelvic floor issues and intimacy, but they're so related, right? Because when women come to me because they're leaking urine, or they're not being able to control stool, or for that matter, they have something called pelvic organ prolapse. Now, again, for the audience who may not be familiar what prolapse is, so prolapse is essentially where basically patients feel that they have a ball or a bulge that's coming out through the vagina. And that's because of weakness of the pelvic floor support structures. Your pelvic organs, which could be the uterus, the bladder, the rectum, or the small bowel, are essentially trying to push through the vaginal canal. So it's essentially a sort of hernia, except through the vaginal wall. But when patients come to see me, of course, they're coming in because of the pathology. But when we do a detailed history, when we talk about all this, it is so common for the topic of intimacy to come up, because as you can imagine, I have patients ranging from their 20 years old all the way up to 90, if not older, right? And at different points of their life, intimacy affects them in different ways. So as we were talking about a young woman who maybe just had a baby and now has a fistula, and now instead of having bowel movement through her anal opening, that stool is coming out through the vagina. I mean, you can imagine how traumatizing that is, because not only is she a new mom going through all the hormonal changes, she already has body image issues because her postpartum body may not look like what it used to be before she had the baby. And now she has to deal with this added trauma of, oh my goodness, now I have stool coming out through the vagina. Am I even going to be like, what is my partner going to think about this? Is this going to be fixed, right? Similarly, I hear it all the time, like women who have leakage. So something we call stress urinary incontinence, which is basically leakage of urine with any kind of activities or physical exertion, whether it be exercise, jumping, walking. Sometimes we have something called coital incontinence. So these are women with orgasm will have leakage of urine. Again, they are so embarrassed to the point where they don't want to be intimate to their partner. And these are such sensitive topics that no matter how understanding your partner is, I think most women and most patients don't feel comfortable revealing that to their partners. Like I have patients who come to me with prolapse, and they don't want their partners in the room because they don't want the partners to see what exactly it is that they have. So as you can imagine, how much of a psychosocial impact that can have on the patients, and as a result affect them being able to be intimate with their partners.
Absolutely. I can definitely see that. I'm just curious, and I'm not sure if you would know the answer to this. And so that's why I'm asking, because I don't think I know the answer. Is that, when you talked about the coital incontinence, I'm curious to know if that is sometimes seen as squirting, or ejaculating for women. What are your thoughts on that?
I don't think so. Like, I mean, I'm talking about patients who legit like have leakage of urine, right? Because they also have leakage of urine, like we talked about with stress incontinence. So this is not like, just vaginal lubrication or discharge. It's literally urine that can come out. And I think the reason for that, a lot of the times, it's because the support of the urethra is compromised for the exact reason we talked about, whether it's pelvic floor disorders, whether it's pelvic floor muscle weakness. And then when that support is compromised, they're not able to support that. So when you have a really, like when you're having an orgasm, it's a lot of increase in your intra-abdominal pressure. So that can cause women to have leakage of urine. So I think, like when I'm referring to coital incontinence, like I'm talking about leakage of urine, like we would in the realm of stress urinary incontinence.
So you're talking about like a lot of leakage, because I think that they think that squirting is a little bit of, can be similar to like male ejaculate, but also
Yeah,
combined a little bit with urine.
with the
Um,
urine.
but you're talking about like actually like a lot of
Yeah.
urine
Right. And
being.
sometimes, we see it even women who have what we call overactive bladder, so these are women who feel like they have a lot of urgency, frequency, like not being able to control their urination when they're in the bathroom or when they have the urge to go. And so a lot of the times they'll have bladder muscle spasms where they're not able to control the urine. So they don't even know half the time when that's going to happen. So when that spasm happens, they'll have an accident. And again, they're very much like embarrassed by that. They're very like sensitive about that to the point they're actually limiting what kind of activities or what kind of relationship or they're engaging in.
Yeah. Yeah. No, absolutely. I mean, any type of incontinence or leakage of whether it's stool or if it's urine is definitely debilitating for women. And I think a lot of women definitely do, curate where they go and how close they're going to be to a bathroom and what activities they do, whether or not they can exercise, whether or not they can jump and run and things like that based on if they're going to leak urine. So absolutely, that's definitely a huge problem. Now, when you have patients that come into you for, say it's like overactive bladder, or if it's, stress incontinence, I mean, those are different things. But, for patients that do have leakage of urine, say when they're running or jumping or doing physical activity, any type of pressure in the abdomen, what type of evaluation are you doing in the office?
Yeah, so when I see a patient for the first time in my office as a new patient, right? Like we were talking about before, so I start with a very detailed history. No matter what they come in with, so they could come in because they think they're having just urinary leakage or prolapse or one isolated thing, but I make sure that I go through all the different conditions that could be because every pelvic floor disorders are related. So I'll ask them about, what kind of leakage they're having. Is it leakage with laughing, coughing, and kind of physical activity, or is it urgency related leakage? Because as you mentioned, there are two different things. There are different kinds of treatment modalities for each one. Are they having any sensation of vaginal bulge? Are they having bowel issues? Are they having constipation? Is there pain with intercourse? Because a huge component of why women may be avoiding intimacy is because they have what we call myofascial pain syndrome, which is completely different than prolapse. Because prolapse, no matter how bad it is, whether it's a stage 4 prolapse, will not cause pain. So anytime patients tell me that they have pain with intercourse, then I'm already thinking there's something else going on. Whether or not they have vaginal dryness, especially on my menopausal patients, right? They have pain with intercourse because of the vaginal atrophy. So once we do a full history, then I go ahead and do a very detailed pelvic exam, which is similar to what you may expect at a GYN office, except we do a lot more specific measurements. Again, looking for things like any prolapse, whether or not they're emptying their bladder properly. So we check for something called PVR, which is a post-void residual. Because, if I'm going to be starting a patient on medications to help with urgency, I want to make sure that they're not going to go into retention. And so after we've done a history, after we've done a detailed exam, so then, depending on what pathologies I think is the main issue, we talk about the various treatment options. And that could include surgical options as well as non surgical options. I think a common misconception a lot of patients have is, especially when they come to see me, because my title says I'm a surgeon, that surgery is the only thing I'm going to offer them, right? And that's far from the truth because a lot of our conditions that we treat has very well established non surgical treatment options. And so for patients who might prefer that, that's something we discuss. And then together we come up with a plan that works for each individualized patient.
Well, that's great. That's good to know. And I think that that is definitely true. I think a lot of patients, will have that hesitation of coming to you if they think that the only thing you're going to offer them is surgery. Now, let's talk a little bit more about intimacy and how patients who have prolapse. So, when when we're referring to prolapse, it's something that's coming through the vaginal vault. How do you best counsel your patients on, intimacy regarding prolapse? I guess it depends on how
Yeah.
bad that prolapse is.
Absolutely. But I think, to your point, there's some basic things that patients should know, right? And I think I was alluding to it before, is that no matter how significant the prolapse is. So when we stage prolapse, so we can go actually from stage 0 all the way to stage 4. So stage 0 is no prolapse at all. Stage 4 is pretty much their entire vagina is everted out. So these are patients who feel that there's a ball in between their legs. So that's not subtle. And stage 2 would be something that's kind of right at the middle point, like at the level of the vaginal opening to within a centimeter. So what I want patients to know is that even with stage 4 prolapse, you should not have pain, whether it's with intercourse or with movement or exercise. So when patients come to me because they have pain or they want surgery because they think that that surgery will fix their pain, that is something that I want them to know that that's not the case. 99% of the time when patients come in because they have pain, it's because of something called myofascial tenderness, or that's because their pelvic floor muscles are tender. They have, like these, what we call trigger points that are very sore, very, tender. It can cause some referred pain. So for some patients, they'll even have pain in their lower abdomen, could be in their buttocks. They also have urinary symptoms where they feel like they're not able to empty. They feel like that urinary urgency sensation. So that's a completely separate pathology. So that's one. The other thing, as you can imagine, for somebody who may not be familiar, to even see that something is protruding through the vagina can be like very scary, because majority of the times they're worried that, oh my God, is that my inside organ that's just coming out? So that's the other thing I try to tell patients. I always show them some drawings that even though we commonly use the term that, oh, your bladder is dropping or your rectum is dropping, but what's actually coming out is either your vaginal walls or maybe the uterus. So even for my patients who may have a stage 2 prolapse, I assure them that if you want to be intimate, that's okay. Nobody is going to cause harm just because with vaginal penetration because you have prolapse. And in fact, believe it or not, 1 in 2 women and pretty much 50% of women who have had vaginal birth will have some level of prolapse. But again, doesn't mean that we need to be treating everyone. We treat, especially I treat women who are symptomatic. So these are women who are bothered by the bulge. It's affecting their quality of life. They're debilitated by the fact that there's a ball hanging out. But to your point, you cannot make it worse with being intimate, whether it's vaginal penetration or any other kind of sexual activity, and nor should it cause pain. And so when any of that's happening, then you need to go see a specialist.
Yeah. And I think the key thing that you mentioned with the prolapse and the pain, I think that's really important to make that distinction because you definitely, I think one resource that gynecologists don't use enough of, and perhaps you being a urogyne, perhaps you use them more, is physical pelvic floor therapists.
Absolutely.
And I think that, really more people should use them because of how beneficial it is. And especially when you talk about, the muscles inside of the pelvis being really tender and sore. And that can happen, even with us sitting all day, right? If we're always on the computer, if we're, our pelvic floor muscles can get really tight. And I think it's really important to be able to go and see that pelvic floor therapist because they can help you, especially if you have like chronic constipation, that they can help as well with that because those muscles do get really tight.
Yeah.
Do you see a lot of vaginismus in your office?
I think just the way, so in theory, I could be seeing those patients, but just the way my practice is, like we're so busy doing, basically like some of the conditions that I already mentioned. So in my practice, a lot of the generalists actually deal with like the vulvodynia, vaginismus, and those patient population. And then pretty much like anybody that they cannot treat or somebody who may have some additional pelvic floor issues, those get referred to us. And actually, before I forget, to your point about the pelvic floor exercise, I do want to mention one thing for the audience is because sometimes, and actually most of the times when we think about pelvic floor exercises, we're always thinking about Kegel exercises, which is basically learning how to tighten your pelvic floor muscles. And that's great, but it's not just about tightening the muscles and contracting the muscles. A very important part is knowing when to relax your muscles. Because what happens is a lot of patients, they may think that, oh, you know what, I'm going to prevent, having to go to the doctor. I'm going to start my Kegels. And that's great, but you have to do it in the right way. Because just like any other muscles in the body, if you're not relaxing those muscles after tightening them or contracting them, then that can again cause that myofascial pain syndrome that we're talking about, because then your muscles are chronically in this flex, in this contracted phase. And just like, your biceps, if all I'm doing is bicep curls and not learning to relax those muscles, it's just going to end up being a really sore bicep. The same thing can happen with your pelvic floor muscles. And so then that basically kind of, fast forward a few more months, few more years, they end up with those tight bands where now they're just in a lot of pain, where, they're being affected with intercourse or movement or any of those conditions. So the two go hand in hand, learning how to tighten your pelvic floor muscles, but learning how to relax them. And I think to your point, that's where working with a good pelvic floor physical therapist can be really beneficial, because you need to know why you're doing it and do it the right way.
Yeah, absolutely. I think that, and also, I think that the way that we learn it, is that you have to stop and start your urine. I don't even know if that's the correct way to do it. I mean, when I talk to a pelvic floor therapist, she's like, oh, that's really not the way, we explain it. And so I think that there is actually probably a better way to be practicing Kegels than the way that we learn. And so when you have patients that come to you and let's say they need surgery or something like that, how does having surgery affect their intimacy? So now, they fix their prolapse, or maybe they fix their, bladder incontinence or something like that. How do they usually come back to you and let you know how they're doing with their intimacy? I would imagine that it's probably much better.
Yeah, no, for sure. And I think that's a very valid question, right? And that's a very important question, because like we talked about, for a lot of women, of course, the prolapse or leakage, it's bothering them, but a big component is their relationship with their partner. So of course, that is a big thing that we discuss, right? So thankfully, there's been a lot of changes in even the different surgical procedures that we do, that has significantly improved patient outcomes with regards to intimacy. Now, sadly, we don't have a lot of literature specifically looking at just sexual function after pelvic floor surgery. And that is definitely an up and coming topic that we talk about at all our national meetings. What we do know is, women who may have had mesh complications. So, for example, forced stress incontinence, which is basically leakage of urine with exertion. One of the most common procedures, in fact, that's really the gold standard procedure that we do, is something called a sling procedure, where we put a tiny piece of mesh under the urethra to help support the urethra. Now, anytime I even start talking about that topic, women just have these visuals because they've heard like so and so have a really bad experience with it. They've had so much pain with intercourse afterward. They've had a lot of vaginal discharge. The mesh was going into the different organs in the pelvic area. And I spend a lot of time with my patients kind of going over that history. So yes, so early in 2000, there were a lot of controversies about mesh. A lot of women who had mesh surgeries, whether it be for prolapse, whether it be for incontinence, were having complications. But then we also learned a lot. So my specialty, so like I said, urogynecology was born kind of in the early 2011, 2013, kind of started because we realized that we need specialized surgeons who understand the nuances of these surgeries, right? Because it's not about just doing the surgery and letting the patients leave. If patients have complications, we should be able to help them with it. And we realized that not a lot of people were able to do it without the specialized training. So that's kind of how urogynecology was born. And then also with regards to mesh, because I think there's a lot of negative associations that patients in general have with mesh. I always tell patients, mesh is just a tool, right? It's not just about the tool. It's also, there's so many factors, right? Who is doing the surgery? Are they doing the right surgery for the right indications? Not to mention the quality of the mesh is very different than what we used to use before. So a lot of that has changed, improved patients' outcomes with regards to intimacy after surgery. Some of the prolapse surgeries, we talk about something called a posterior repair, where, we're basically fixing the back vaginal wall for women who have their rectum kind of pushing through. We do sometimes see that women have pain with intercourse after that kind of surgery, but nothing like what we used to do before. And I think part of that is also because, those of us who do these kind of procedures now, go through specialized training, we see a lot of, what works, what doesn't work, and that has definitely improved patient outcomes for sure.
Mm. So do you, after patients have like, say like this anterior and, possibly posterior repair as well, fixing basically the bladder from, after it's come down, and also the rectum, or from when as it's pushing up into the vagina, do you ever have your patients use like dilators or anything like that? Or usually it's probably the pelvic floor therapists that do that?
Yeah, so thankfully, so not somebody that I had done surgery on that I've seen cause it, because I'm actually really conservative when I'm doing the surgery, right? Because one thing I always tell my patients, the vagina, even though we're doing reconstructive surgery, it's different than plastic surgery, right? So for example, when plastic surgery does a breast reconstruction, it's something that you're just looking at. You're not using the breast like you would a vagina. So with the vaginal reconstructive surgery, we have to be very careful that you're not just making the anatomy look normal. It has to be able to be a functional organ. So when we're doing this reconstructive surgery, the idea is not to just tighten the vaginal canal so it just looks perfect. Because if there isn't a little bit of laxity, then those are the patients that end up having a lot of pain. And that's what we used to see historically, right? Because we used to do things like levatorplasty, where you're bringing the levator muscles together, causing a lot of tightness. So those women will have a lot of stenosis afterwards. So thankfully, I haven't seen any of my own patients come back, but I have seen patients who may have had surgery before at other places, because so much of the vaginal tissue was removed to basically tighten the vaginal opening. Now there's basically no elasticity in that vaginal tissue, and they essentially end up with a stenotic vagina. And unfortunately, there isn't much to do afterwards besides, like you said, kind of working with dilator therapy. Every now and then, we can make some relaxing surgical incisions to kind of open up the vaginal canal a little bit. But as you can imagine, the more you cut into an area, the more scar tissue you cause. So you kind of have to weigh the pros and cons. So wherever possible, we do kind of try to be conservative for those patient population.
Yeah, I mean, I would assume that you definitely don't want to mess that up and cause more problems for people, right? Than before
Yeah.
when they even came to see you. So absolutely. Now, I think that, what would you say in terms of reasons why people come and see you? Like if you were to, give the people listening to this podcast a clinical pearl, when is it that they need to come in and see you? Because I'm sure they go in and they see their gynecologist if they're having some issues, but when is it time for them to come and see you?
Yeah, I think, the one thing that I want patients to take from our conversation is that, all the pelvic floor issues that we talk about, whether it be leakage of urine, prolapse, bowel issues, many times they can be very common. It can be very common in women who have just had a child or just had a baby. It can be women as they're going through menopause and their body is going through different hormonal changes. And of course, it could be common for somebody who's been kind of suffering with it for many years and always been told that, oh, it's a part of aging and it's fine. It's not a big deal. It's not killing you. Yes, most of these conditions are not life threatening, but as we kind of talked about, they can have some significant impact on patients' quality of life. So I don't want patients to think ever that it's normal to have any of these conditions, right? Whether it be leakage of urine, whether it be leakage of stool. At no age is it normal to have any of these conditions. And if nothing, even if you don't want any kind of intervention, it's always good to get an opinion, to get a second opinion from seeing a specialist, at least know what your options are. And then you can decide if the treatment is for you, is now the right time to get them, or is it a different time? Like I have many patients, for example, a lot of my young patient population, like after they have a baby, maybe like, at 3 months, 6 months, come and see me. And, they're like really affected by the incontinence. They're really affected by the prolapse. But I tell them like, look, you just have a new baby, you're breastfeeding. This is not a time when we should be talking about surgery. They may want more children, but then we talk about what are the options. So that's a perfect patient where we start on like a pelvic floor physical therapy to help strengthen their pelvic floor muscles. And then maybe, 5 years later, when they come back to me and say that, hey, Dr. Noor, I'm done with my children. Now I want to get it fixed. So to answer your question, it's a very convoluted way of answering it. But my point is, if you think something is happening in your body that doesn't feel normal to you, of course, start with talking to your primary care doctor, start by talking to your OBGYN. And, if it is something that's there, have them refer you to a urogynecologist, if nothing, at least to get a consultation so you know what your options are. You can get evaluated, and then you decide how you want to proceed.
Yeah, I think that's key. I think that knowing for patients, that there are options out there, that it isn't hopeless. I think that's one of the key takeaways I think that I would want somebody to get from listening to this podcast, because I think oftentimes when women are suffering, they think it's just a part of aging, or that's just happens, after they have children, and it's just a part of life and it's normal. And that's why we have like all these older women in diapers, right?
Hmm.
Because they just have felt like, well, I leak urine, but that's okay because,
Yeah.
that's just what's going to happen, right?
Yeah.
Instead of somebody telling them that, no, you don't have to suffer like this. You don't have
Yeah.
to go through life leaking urine and wearing a diaper, right? And
Yeah.
I
And
think
believe
that,
it or not, it's more common than women think. The problem is we don't talk about it because it's just such a sensitive topic. It's such an, embarrassing thing to be talking about. And of course, like, I have my older patients, and once they've had a surgery and they're doing great, now they want to talk about it. And they're like, oh my God, like my friend who I've known for 10 years also has it, and I had no idea. And same thing, right, for young women. I mean, those of us who treat patients, we know like how common all these conditions are postpartum. And yet, these are not things that we talk to patients about. And, so when it happens, they're shocked, they're traumatized because they think this is what they have to live with for the rest of their life.
yeah, yeah. And I think that's really important. So, for anyone that's out there that may be experiencing leakage of urine, or, any type of prolapse, or feel that there's something coming out of their vagina, really important to be go to your gynecologist, be taken a look at, examined, so that if we need to refer you to a specialist like a urogynecologist like Dr. Noor, that we have all the information to refer you to them, because you don't have to go through life with all of these symptoms happening and these things happening. You can actually have it fixed and addressed, and it definitely will improve your quality of life and your intimacy, for that matter, right?
Absolutely, 100%. Because, anybody who's having these conditions, it can take a huge toll on how they perceive themselves, their body image, their confidence, and all that, as you can imagine, can have a negative effect on them feeling good about themselves, feeling beautiful, and thus affecting intimacy for sure.
Yeah, absolutely, absolutely. So really important. Any last pearls that you would want to give? I know we talked a lot about the incontinence, we talked about the prolapse, we talked about different options and surgeries, and how you can improve your quality of life by having these things addressed. Anything else that you'd want to tell people about?
Yeah, and I think the fact that your podcast is about it's like a Muslim sex podcast, because again, I think one of the things we didn't kind of touch on is that there's a whole cultural aspect of it too, right? Like we see it a lot in women, especially in women who may be Muslims, or in the South Asian community, which I have a huge patient population that's Middle Eastern, that's of the South Asian descent, and we see that they may not be prioritizing their pelvic floor issues as say compared to a cardiac issue or something like cancer, right? And yes, I mean, thankfully, what we deal with is nothing like cancer, nothing like a heart condition that could be really life threatening, but not to but to think that it's not important and that this is not priority for me, maybe not at this point. I think it would be not taking care of yourself. So I would definitely want to emphasize that yes, while it may not be a life threatening issue, some of this can have some significant impact on patients' lives. And it may not be obvious even to the patients themselves, but having taken care of these patients and seeing how much their lives changed, just, from every aspect, once, they feel better about themselves, these conditions are treated, I definitely think that's an important thing to consider. And the good thing is we have such amazing treatment options, right? Especially in today's day and age, when I see somebody who is maybe suffering for 10 years or have never seen a provider, it really breaks my heart that they've been suffering with it for so long, even though we have such amazing treatment options for these conditions.
Yeah, I think that that's a very valid point. I just want to say that, it's not just Muslim women, right? Like it's
Absolutely.
women throughout. It doesn't matter what religion or race or ethnicity you are. It's really about women prioritizing their health, their health conditions, their pelvic floor, all of those things. I think that women in general don't tend to prioritize themselves or their health because they're so busy taking care of other. We're always the
Yes.
caretakers, right?
Yes.
We're taking care of our kids, our spouses, our parents, everyone else besides ourselves. So I think that for anyone listening, I would say that it's really not just, and although my podcast is called the Muslim Sex Podcast, it's really not just for Muslims. It's for anyone
Everybody.
that may be listening and, finds value in it. And I think that it's really important to know and to understand that just to prioritize your health in general.
Yeah.
And if you are having any issues with, leaking of urine, any issues with leaking of stool, with perhaps, feeling something that's coming out of your vagina that, you feel a bulge or something like that, you feel like, maybe your uterus is coming out, any of those things are definitely reasons to come in. Obviously, you come to your gynecologist for multiple reasons, but these are definitely things that you should prioritize. And, feeling like you have to leak urine for the rest of your life, or you have to run to the bathroom, or you have frequency or urgency, whatever, any of those things, definitely go in and be seen,
Yeah.
so that if you have any issues that they can be addressed, because for the most part we can address most problems.
Yeah. And the good thing is a lot of this, even if, your provider or your doctor recommends surgery, most of the surgeries I do, patients go home the same day. So these are what we call minimally invasive surgical techniques. So which is very different than, what people maybe, used to maybe even 5 years ago. I mean, you know it, right? I mean, hysterectomy now we do, and it's patients are going home the same day. And so when I say, because I do a fair amount of hysterectomy for patients with prolapse, so when I talk about hysterectomy, in their mind, they're thinking about, oh my God, my mom had hysterectomy and that was a whole week of staying in the hospital. It's nothing like that now, right? I don't even remember the last time one of my patients stayed overnight because again, there are medications, with some of these new surgical techniques, patients do really, really well post-operatively as well. So that's another thing that I want them to know.
Excellent. Well, that's so great. And it's so good to know, and lots of information here, and important for patients to know that there is definitely, less invasive surgeries where they can actually go home same day. That's amazing. That is fantastic, because even, when people do like vaginal hysterectomies, I know that definitely as providers, at least when I was doing my residency, which was a while ago, that we were keeping patients, at least overnight, if not 2 nights. So that's great. Good to know that, people are just going
Yeah.
home the same day, which is excellent.
Yeah.
So for those that are listening and are wondering, how they can get in touch with you and where you're located, maybe how can people get in touch with you?
Yeah, absolutely. So I think, the easiest is probably my social media. So I just recently started a YouTube channel where actually, I'm starting to make these small educational videos for patients. And it was started because I would get patients asking me like, hey, I saw, so many other doctors make these videos. You should start making them too. And it's been really helpful because, it kind of gives me a platform where I can talk about some of these topics, and they're always there. So patients can definitely look at it. And even not just patients, if you're somebody who is in the healthcare field and want to learn more about some of the conditions we treat. So that's, my name. So Dr. Nabila Noor. You can also find me on Facebook as Dr. Nabila Noor, Instagram. And of course, if you're in the Allentown area or, close by and you need to see a urogynecologist, I'm always here, happy to help. So those are probably the ways to get in touch with me.
All right, excellent. Well, thank you so much for coming on and providing so much value and letting us know, the different types of treatments that are available for women that may be suffering with fistulas or incontinence or any of those issues that sometimes do affect women. And good to know that there's so many therapies out there. So, well, we are done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you're having any issues with your pelvis or a leakage of urine or any of those things that we talked about, please go see your gynecologist, who then can refer you to a urogynecologist that can help you out. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.